بسم الله. اتفضل دكتور عبد الله.
Yeah. Bismillah ar-Rahman ar-Rahim. Today we will discuss advances in geriatric dentistry. In today's presentation, we will discuss the following topics. First, I will present a brief introduction to geriatric dentistry and geriatric patients, and then we will discuss cognitive assessment for geriatric patients, minimal invasive treatment options for fragile dentition and older patients, age-friendly prosthodontic solutions, implant-supported overdentures, teledentistry, and personalized oral hygiene programs for elderly patients. Now, what is geriatric dentistry? Geriatric dentistry, also known as gerodontology. It's a specialized area of dentistry that deals with the delivery of dental care to the older adults, involving diagnosis, prevention, and treatment of problems associated with normal aging and age-related dentistry as a part of interdisciplinary team with other healthcare professionals. Now, who are the geriatric patients or the older patients? There is no generally accepted definition for old age or old adults. However, according to the World Health Organization, most developed countries have accepted that chronological age of 65 years as the threshold for categorizing an individual as an older adult. This definition is somewhat arbitrary because it doesn't consider the biological age of the patient. And as we know, the chronological age is not a synonym for the biological age. Okay, so we can consider this age or 65 years as an arbitrary definition for older adults. Now, for the epidemiology, in 2004, the Australian Bureau of Statistics conducted a projection study to estimate the age of the Australian population for the period from 2004 to 2101. In this study or in this projection, they concluded that in 2004, the people aged 65 and more made up 13% of the Australian population. And the projection indicated that this proportion will gradually increase until it reached 29% in 2101. Therefore, we can conclude that geriatric population is a continuously growing segment of the community. Okay. Now, classifying the geriatric patients allow for more accurate analysis of the variation within this age group and make the diagnosis and treatment planning for this age group more personalized, depends on the patient's need. So we can classify the elderly patients or the geriatric patients based on their chronological age or based on their functional needs. The chronological age, as all we know, it's the amount of time that has passed since birth. However, the functional needs is the patient's ability to seek the dental care independently. So these are two types of classification that we can be used to classify the geriatric or the older or the elderly patients. Now, sorry. For the chronological classification, elderly patients fall into three main categories based on their chronological age. A new elderly represent those aged between 60 and 64 years old. Transitional group represent those aged between 65 and 75 years old. And finally, older elderly represent those 75 years old and more. However, due to the inter-individual variation in physical, mental, and medical health, okay, as we said before, the chronological age is not a synonym for the biological age. So there is a variation between the patients يعني حتى لو كانوا بنفس الفئة العمرية ممكن يكون بيناتهم فرق. So the chronological age criteria have limited use in dentistry. Therefore, a dental classification system for aging based on the patient's ability to seek dental care independently would be more useful for dentistry. Now, based on the patient's ability to seek dental care independently, Ettinger and Beck in 1984 classified older patients into three main groups: functionally independent, frail, and functionally dependent. Functionally independent patients who are able to maintain independence in seeking dental treatment or diagnosis and so on. The frail patients, they are the patients who are unable to maintain independency without continued assistance by an association or by the caregiver. They are usually live in the community with support service. They usually receive support service. However, the functionally dependent patient, they are also unable to maintain independency. However, they are usually homebound or institutionalized. يعني عادة بيكونوا يا بدور الرعاية يا أما بيكونوا بالبيت. Now, changes in geriatric patients with age, the geriatric population undergoes several changes, including both physiological and physical changes. Physiological changes, often this include a decrease in the efficiency of the gastrointestinal, renal, cardiovascular, respiratory, and immune system, which could impact the entire body, including the oral health. Okay, now for the physical changes including reduced bone and muscle mass, as we see here in the figure. It reach a threshold, then they start to decline. Okay. Also, physical changes include reduced mobility, such as in the cases of osteoarthritis, okay, and audio and visual impairments, such as cataracts, macular degeneration, and hearing loss that can complicate the communication, patient education, and oral health care. So the physical change, in conclusion, include reduced bone and muscle mass, reduced mobility, and audio and visual impairments, which will affect on the patient ability to communicate and educate. Okay. Okay. Most elderly patients have at least one chronic condition, with others having multiple medical conditions. The most common medical conditions encountered in geriatric patients are hypertension, diabetes, arthritis, heart diseases, and cancers. Other prevalent conditions may include dementia, depression, hearing loss, cataracts, as we said before, and back and neck pain. All of these conditions, or systematic condition, or the medications that associated with these systematic conditions may impact the oral health of the geriatric or of the older patients. So the dental treatment of this age group considered as one of the most challenging treatment in our field. Okay. Now, after we talked about the medical condition, now we will talk about the oral conditions of geriatric patients. We can classify these conditions based on their effect on salivary flow, oral mucosa, teeth, and periodontium. Okay. Now, for the salivary flow, dry mouth or xerostomia is highly prevalent in older adults, and it's commonly linked to drugs. As we know, older patients usually are polypharmacy, so they took multiple drugs that may cause the dry mouth or the xerostomia for the patient. Drugs that may cause xerostomia include antidepressants, antihypertensives, inhaled medications such as salbutamol, and the diuretics, okay, which is diabetic drugs. Now, xerostomia or dry mouth can result from a comorbid diseases such as the diabetes, Alzheimer's, and Parkinson diseases. Also, it may be caused by the degeneration of the salivary gland function with age and the general dehydration of the patient. Now, xerostomia can be associated with caries and periodontal disease, as saliva no longer serve as a or give us the function of washing and buffering effect, okay, in the oral cavity. So this will result in caries and periodontal disease in geriatric patients. Also, it may cause cracked lip, fissured tongue, and oral mucositis and candidosis, as yeah, for the same reasons. There is no washing effect or no lubricating effect for the soft tissues. It could also have an impact on the patient's quality of life, affecting taste, okay, for the tasting buds, okay, speaking, ingestion of food, عملية swallowing نفسها, and complete denture retention. So, as we know, complete denture retention, the main technique that results, or المين خلينا نحكي اللي هو السيرفس تنشن، هو من اهم الشغلات اللي بتعطيني الفيتنج الريتنشن اوف ذا complete denture. So, in the absence of saliva, this will negatively impact the retention of the complete denture. Okay. After the salivary flow, we'll talk about the oral mucosa, including the epithelium and the connective tissue. With age, or the age-related changes to the oral mucosa include loss of elasticity and stippling of the gingiva, with a general thinning of the oral mucosa over time. Also, with age, there is a lower healing rate for the mucosa, and diseases such as oral thrushes and oral cancers can become more prevalent. Now, these changes result in decreased immunity against pathogens, which render the geriatric patients more susceptible to oral infections and several oral diseases. Now, for the teeth, dental changes occur with aging. تمام. These changes include teeth wear due to continued chewing and general use of the teeth. And as the enamel thins down, the dentine usually show through or even become exposed for the oral environment. Therefore, teeth in older adults, teeth may look more yellow and can become stained more easily. Now, a second change is the dentinal sclerosis due to continuous formation of the secondary dentine with age. Also, calcification of the pulp and root canals narrowing, which often lead to decreased sensitivity to the stimuli. And with age, the rate of the cementum production slowed down, leaving the geriatric patients at higher risk for developing root caries. And finally, with age, the risk of tooth loss increase. Okay. Now, finally, for the periodontium, the incidence of periodontal disease increased with age. However, we cannot, or it doesn't occur, or the periodontal disease doesn't occur due to the nature of the condition. Okay, so we can conclude that the age is not the cause for the periodontal disease. However, it's a risk factor for the periodontal disease because of the cumulative oral history of the older patients with the time. Okay. Now, due to the aging process, certain medications and certain systematic diseases such as diabetes in geriatric patients, the geriatric patients become more susceptible to pathogenic anaerobic bacteria infecting the periodontium and initiating inflammation. As we know, or for example, such as in the diabetes, as we know, the patient will be more susceptible to periodontitis. Also, if the patient taking a drug that causes xerostomia, this may reduce the plaque removal ability, or this will make the soft periodontium more susceptible to periodontitis or periodontal disease. In elderly patients, usually gingival recession exposes the root surface to bacteria, as we see here in the photo, which can lead to root caries. So the root caries in older patients or in the geriatric patients related to two main causes. First of all, اللي هو reduced rate of cementum production and the exposed root surface due to the gingival recession with time. Furthermore, severe periodontal disease can lead to compromised periodontal support and tooth loss. فالultimate results of severe periodontal disease will be the tooth loss. Now, the mouth-body connection. As we discussed earlier, oral health and systematic disease can affect each other. Oral health problems are significant health concerns for older people, presenting risks to both their physical and mental well-being. Usually, tooth loss and dental caries can lead to difficulty with chewing, resulting in reduced oral intake and malnutrition. This will affect the general health of the patient. Also, research linked poor oral hygiene with the occurrence of aspiration pneumonia and multiple other systematic diseases such as diabetes, hypertension, and dementia. Therefore, to reduce the risk of serious complications, or older adults need or always need a professional dental care. Okay. Now, cognitive assessment in prosthodontic treatment planning for geriatric patients. Now, cognitive dysfunction is a serious public health issue affecting 1/3 of the Americans aged 71 years and older. The cognition in general is a critical dimension of function that usually regulate the oral health related activities such as toothbrushing, managing denture, following post-surgical instruction, and using medications. So the cognition هي عملية الإدراك للpatient, okay? And the cognition may be impaired or yes, it will be impaired with time as a result of several systematic diseases such as Alzheimer's diseases or some vascular diseases. As a result, cognitive dysfunction may complicate prosthetic treatment, increasing the risk of an unpredictable outcome and implant failure. For this reason, dental assessment and treatment planning or the prosthodontic treatment planning should incorporate cognitive assessment of patients with dementia and cognitive impairment as we said before, such as in the Alzheimer's disease. Cognitive assessment can help us as a dental professionals in identifying the candidate suitable for the proposed treatment, design safe and effective intervention strategies, minimize unnecessary treatment, and improve the quality of care of cognitively impaired patient. So I can conclude that if the patient has a cognitive impairment, we should assess him and we should provide the treatment personalized to the special case of this patient. And for assessment of the cognitive dysfunction or to assess the cognition in the patient, we may ask the caregiver about the status of the patient. Also, we can asking the patient to repeat or demonstrate the instructions and verbal communication. And finally, we can assess the cognition using objective cognitive assessment tools. It's an objective tools that can be used to assess the cognition of the geriatric or older patients. For example, mini mental state exam, it's an objective, reliable, and easy to use instrument to assess dentally related function in cognitively impaired patient. The mini mental state exam used to assess 6 areas of mental abilities, as we see here in this paper. The 6 areas including orientation of time and place, attention, short-term memory, or also called as a recall, language skills, visual spatial abilities means visual and spatial relationships between objects. As we see here in this figure, they ask the patient to redraw this figure. Okay. And finally, it tests the ability to understand and follow instructions. After the patient complete this test, usually the mini mental state exam score out of 30. and the test usually takes about 5 to 10 minutes. So it's an efficient way to assess the cognitive abilities of the patient using an objective method. As we see here in the figure, a score of 25 or higher is classified as a normal patient. So the patient who scored 25 and more is considered as a patient with a normal cognition. However, if the score is below 24, the results is usually considered abnormal, indicated a possible cognitive impairment in the patient. Now, minimal invasive treatment options for fragile dentition. As we discussed earlier, the geriatric population is a continuously growing section of the community, and the expansion of the older population and the concomitant reduction in the level of edentialism result in an increase in the number of older patients presenting in general practice with a complex restorative challenges. So the older population increased with age, and the edentialism in this age group reduced. And so the patient who retained older patient who retained natural dentition is increasing in overall. تمام. Therefore, the application of the concept of minimal intervention dentistry may offer a powerful armamentarium to the general dentist to provide conservative treatment to the older patients. The minimal intervention dentistry is the complete holistic treatment or team care approach to patient-centered prevention of disease and management of oral health in the long term. Okay. Minimal invasive dentistry is centered on the prevention and curing of dental caries and employing minimal invasive technique when operative intervention is unavoidable. In other words, minimal invasive dentistry include both prevention or preventive interventions and minimal operative interventions. So either preventive interventions or operative or minimal operative interventions. Okay, for the preventive interventions in older adults, or the preventive interventions in older adults include patients and or caregiver education, patient motivation, diet counseling, and topical fluoride application. Now, preventive oral care usually begin with the risk assessment of oral disease in each patient. In 2013, the ADA recommended the use of topical fluoride in older adults with a high caries risk. And the topical fluoride can apply professionally in the clinic or at home by the patient or by the caregiver. Okay. Professionally, okay. Professionally applied fluoride usually include 2.26% fluoride varnish or 1.23 acidulated phosphate fluoride. However, the home used fluoride include fluoride with a lower concentration, including 0.5% sodium fluoride gel or paste and 0.09% fluoride mouth rinse. That can be recommended for the older patients in order to reduce the risk of caries in this patients group. Now, root caries, as we discussed before, is common among older adults, and silver diamine fluoride is a type of fluoride that contain a high concentration of fluoride. Usually, its concentration is 38%. Okay. And it can be used to control the root caries in older adults. However, the disadvantage of the use of silver diamine fluoride is the black staining of the teeth, as we see here in the photo. So it's important to inform the patient of this side effect. فبالتالي the older patients are at higher risk for root caries, so we may use the silver diamine fluoride, which have a high concentration of fluoride in order to arrest their caries, root caries. The researchers suggested that applying silver diamine fluoride to exposed root surface in older patients once a year is an effective way to prevent root caries in older patients. Now, after we complete preventive interventions, we will talk about minimal operative interventions in older patients, which include atraumatic restorative technique, resin infiltration techniques, repair of existing restorations, and shortened dental arch concepts. All of these concepts apply the minimal invasiveness in treatment. First of all, atraumatic restorative technique. This technique involves the manual removal of caries followed by the restoration of the cavity with an adhesive material such as glass ionomer cement, which will release a fluoride later on, and it can help in arresting caries. Atraumatic restorative treatment is useful for older patients with restricted mobility and those with dental phobias because it does not require anesthesia or and it doesn't require the use of rotary instrument. Atraumatic restorative technique can use chemical caries removal system like as Cariosol. uh, this system or the Cariosol composed of 0.1% hypochloride-based alkaline gel that react with Carios dentine, allowing for easier removal of the infected tooth tissue with hand instrument. And it's usually work with a proteolytic function يعني الميكانيزم of action تبعه proteolytic. Okay. A traumatic restorative technique has shown a comparable survival rate to conventionally placed restorations in older patients. So it's efficient, have a good survival rate, and it can be used in خلينا نحكي special cases where the patients have a dental phobias or they have a restricted mobilities or يعني other conditions that may indicate this treatment option. Now, for resin infiltration technique, the resin infiltration technique involves the infusion of resin into porous enamel through capillary action, thereby arresting early carious lesions, which is the white spot progression. This technique includes the application of 15% hydrofluoric acid gel to the tooth surface for 2 minutes. Then we wash the tooth structure or the tooth surface. Then a low viscosity resin, usually we use Tegdima, with a high penetration coefficient is added. Usually the penetration coefficient should be at least 200 centimeter per second in order to use the resin in this process. Now, based on the extent Okay. Now, based on the extent of caries, the resin infiltration technique is recommended in cases where caries does not extend more than 1/3 in the dentine, including E1, E2, and D1. فبالتالي عادة بنستخدم we use this technique in all cases except in the cases where the caries reached or خلينا نحكي إنه قطع 1/3 of the dentine. Okay. Now, the repair of existing restoration, when treating secondary caries, replacing restoration cause a loss of tooth structure, which is in turn reduce the tooth longevity because we removed an sound tooth structure while we replaced the restoration. Therefore, when treating secondary caries, it's more conservative to repair rather than to replace a restoration, especially in patients in older patients. Okay, many older patients may present with old ceramic or metal ceramic fixed prosthesis with chipped veneering porcelain. These restorations have served them for many years. So they may be reluctant to have their prosthesis replaced. Therefore, repair of chipped veneering ceramic should be attempted or should be considered in the first instance of failure in older patients. When a small chipping occur in an anesthetic area, as we see here in the upper photo, it's an anesthetic area and it's a small chipping. The easiest way to repair this chipped veneering porcelain is to polish the fractured surface. فبنقدر نعمل بولش هون وهون يعني الامور بتكون تمام. However, in other cases, such as in the aesthetic areas, or in the cases where there is a bulk fracture and the core material show, here we need to repair the fractured part using either a composite-based resin, or we can repair it by preparing the restoration and or preparing the restoration for new veneer and adhesively bond the new veneer to the existing restoration using resin cement. فبنعتبره الكور ماتيريال as tooth ونعمل له preparation و we cement or adhesively lute the new veneer. Now, repair chipped veneering porcelain. The challenge in repairing chipped porcelain veneer with composite or with a new veneer is to create a strong mechano-chemical bond between the resin-based composite or the resin cement and the fractured surface of the restoration, which frequently consists of two different materials. Chairside repair of chipped veneering porcelain require two main steps: surface conditioning of the fractured surface, and the second step usually is the bonding of the new veneering ceramic using the resin cement, or the application or direct application of the resin composite. Now, for appropriate surface treatment of the chipped restoration, usually appropriate surface treatment depends on the type of the material exposed on the fractured surface of the prosthesis. For glass ceramics, we should use hydrofluoric acid etching for the surface. However, intraoral use of hydrofluoric acid is controversial because its hazardous properties. Therefore, the clinicians should avoid using hydrofluoric acid if possible, and they should never use it without the rubber dam application. After the hydrofluoric acid etching for the glass ceramic, we apply the silane coupling agent under the rubber dam isolation. Okay, and by that, the surface will be prepared. However, for oxide ceramics and metals, we should use intraoral air abrasion using 50 micrometer aluminum oxide particles, because these materials is not susceptible for etching by hydrofluoric acid. Okay. For after the air abrasion, we can apply acidic monomers such as 10 mdb or 4 meta onto the surface of the oxide ceramics or the metals, or we can use a silane coupling agent after